Organizers for giving me an opportunity, as Dr. Anuj already said, with esteemed stalwarts of critical care. I think it's always an honor to be in front of our teachers. So I'll be talking about antibiotic stewardship. It's impossible to implement in the Indian ICU, or for that matter in any ICU. So that was what we were asked to talk about. But I would believe it is possible to use antibiotic stewardship. Let me start first with whatever Dr. Rajesh has spoken. From the beginning of his talk to the end of his talk, I could only see him expressing a whole lot of helplessness in this thing, which I thought was not a right way to start. He went on saying about GST, one tax, one country, not possible. Well, let's give it a chance. We have to see it's possible. He said, that's the reason from my talk I eliminated the word Indian ICU, because as far as I am concerned, I am a nationalist and I think we are not less than anyone else in the world. He is quoted about one study which said that it is not possible in our country. But fine, if it's not possible, let us learn from other people's problems, what mistakes they have done, and I'm sure it's possible to adapt a lot of things in our intensive care units or in our healthcare as well. Let me start with a simple thing, definition. The IDSA has given as recently as 2016, and as mentioned in the previous session, this is a guideline, came after 2012, so I think it will be having reasonable credibility is what I would say. So the definition is very simple. Just tell me if it is very complicated. If you're not understanding, let me explain it to you. Coordinated interventions designed and used to measure appropriate use of antibiotic agents by promoting the selection of optimal drug regimen, including dosing, duration of therapy, and dose of administration. So Dr. Rajesh alluded that we all use antibiotics. I can write antibiotics. We can write antibiotics. So we are already doing it. All we are saying is coordinated, use appropriate guidelines and optimal drug dosing regimen. So it's just about a little bit of understanding what an antibiotic is all about. Is it very complex? I don't think so. What do we need? Why do we need antibiotic stewardship? Dr. Rajesh mentioned in the first couple of slides that we are losing antibiotics. Yes. From the data we know in the last 15-20 years, possibly there is an improved outcome by using antibiotic stewardship. Possibly, it's not very strong, but there is some data to suggest that reducing adverse effects including C. difficile infection. I think this is important. C. difficile, MRSA, these are all known to be bred by massive use of antibiotics. So I think at least if we don't be useful to the patients, I think we should not do no harm. I think that's very important to understand. Improvement in rates of antibiotic susceptibility to targeted antibiotics. Yes, we'll try to rediscover our antibiotics and get them back to be more sensitive. And optimization of resource utilization across the continuum of care. Now this is important because Rajesh went on saying we don't have money, we are not having this, we are not having that, etc., etc., etc. But I think the end result or the end goal of having a stewardship program is primarily to save money in the long term. Now if you invest a little money today, 5 years down the line you will probably get better results, and that is what probably GST is going to do as well. Components of antibiotic stewardship program is very simple. There are some 6 or 7 laid down guidelines, laid down principles, leadership commitment. Now he said, government hospitals are different, private hospitals are different. Why? Because there is lack of leadership. So why don't we all become individual leaders and say we will start from my home, get my home sorted out first, and then spread this message across. And that is a very, very important aspect of antibiotic stewardship. And I'm sure many of the corporate hospitals, many of the private healthcare players do understand this concept. And I think it is us as healthcare providers important to convince the leadership that this is important. This is important not only for the humanity, it's important for the long-term survival of healthcare and for the general public as well. Multidisciplinary team, we all know that ICU is a multifaceted specialty, so what is the big deal? I'm sure we can handle a multidisciplinary setting and put in different stakeholders, bring them on the table, talk to them, lay down guidelines. Situational assessment, yes, we would actually have proper time-to-time assessments. We do it on regular basis. We just have to put down guidelines and take it forward. One of the components is different forms of interventions to improve antibiotic use, which is so because we know that in the last few years of what we have learned about antibiotics, every measure has a very small contribution in changing mortality or changing outcomes, and when we bundle these cares together, it really seems to make a difference in the overall outcome of the patient. Constant surveillance, reporting, and education. Now, education is a part of everything. We are here today as a part of education, so we constantly read. So I'm sure being educated and constantly educating people is a part of a medical healthcare provider and a part of doctor, and this is known since the time of Hippocrates. Now I'll just go through the ideas and recommendations very briefly. It's a big document, but just for us to understand whether it is so complex to administer it in our country. Now, we already heard to Rajesh's perspective, but I'm sure he's a very smart, intelligent doctor, good friend of mine, was a ex-colleague of mine, but I'm sure more than one minds put together is always a little wiser is what I believe. So some of the important recommendations are pre-authorization or prospective audit and feedback to improve antibiotic utilization. So this is the first step. Either you have, at least in select antibiotics, what you have to do is to know where the antibiotics are going, when it is getting started, how to stop it, who is not stopping it, etc. So simple processes can be put into place. Not a lot of money, just have to have somebody who will design a form, who will put out some forms to say that, okay, meropenem is crossed 48 hours, somebody is prescribing meropenem, so just keep a track of what is happening. Various educational activities are important, and not only sitting and speaking like this, you can have pamphlets, you can have different forms of educational activities is what the second guideline is important, and this is all part of education. Develop facility-specific clinical guidelines for common infectious diseases to improve antibiotic utilizations. So say in the south of the country, enteric fever may have a particular outcome, a particular sensitivity, it may be a little different up north. Urban areas have different sensitivities, rural. So it's important to know what your local data is and accordingly have local guidelines. So we are talking about flexibility. We were told in the last talk that there is no flexibility, we can't bring in certain thoughts from the external world or the outside world, but it is possible. The guideline doesn't say you should not do that. And just to remind you again, a guideline is only a guideline for you to actually implement certain improved processes within your institution. Implement interventions for specific infectious syndromes to optimize antibiotic use. So treating an infectious disease is not only about antibiotics, so you need to look at other alternatives on how you can improve the outcomes by non-antibiotic methodologies as well. Employing interventions to decrease the use of antibiotics that can be harmful, such as clindamycin, for example, fluoroquinolones, for example, which can predispose to MRSA, etc. Strategies to encourage prescriber-led review of appropriateness of antibiotic regimens. We are all humans, isn't it? We do have a lot of egos. So why go and tell the surgeon you're not supposed to use this antibiotic? Instead of that, you tell him, you give me what your policy is, we will sit together, we will debate it, we will discuss it. I'm sure a lot of individuals will agree for that. Computerized clinical decision support systems which integrate the electronic health record system at the time of prescribing, and it gets incorporated as a part of your stewardship program to improve the prescribing policy. So we are talking about digitalization, digital India, electronic health recording system. So it's not very difficult, and most of the newer corporate setups are actually starting off with the digital systems. So I'm sure it's not very hard to incorporate this, and it actually makes your job much more easier. Developing and implementing strategies that promote antibiotic cycling and antibiotic mixing. We have known that antibiotic cycling is a little bit of a failure, so now people are talking about antibiotic mixing, which is nothing but using a group of antibiotics alternating for the same disease. Say for example, today you have got a patient who comes with urosepsis, you start with say cephalosporin sulbactam, the next patient you start using piperacillin tazobactam. So it's just a lateral shift in the BLBLI. So that seems to be making a difference, but very early days, probably we need more data. Dedicated PK/PD adjustment programs for specific antibiotics. So you look at or you deliver the antibiotic in an appropriate mode, method, and also in an appropriate either as an infusion or with constant monitoring of the various antibiotic levels. If needed, change your dosing strategies if there are evidence to say that there are better ways of delivering the drug. Encourage appropriate use or de-escalation to oral antibiotics whenever it is feasible, so that makes it even cheaper. promote use of allergy testing in case you find that a particular patient is allergic to a primary drug or to a first line therapy. Instead of going to the second line or a third line, which is a very broad spectrum antibiotic, see if you could employ antibiotic allergic testing and see if you can narrow down back to the first line therapy. Reduce antibiotic therapy to the shortest effective duration. We started from 2 weeks, 10 days, 7 days, 5 days. So we have greater and greater evidence which now says that shorter therapies are better and equally effective. Attempt to develop stratified antibiotic programs than non-stratified antibiotics. So stratified means if you look at different strains of a particular bacteria, say for example E. coli in a neonate, E. coli in an adolescent, elderly or a middle age, you might find that the strains are a little different. So you need to actually stratify your antibiotic sensitivity as per your age group or as per your high risk or your patient population. So in every given institute, you may have to have specific guidelines to a specific age or a specific subset of patients, which we now know better as personalized medicine. Selective and cascading report of antibiotic sensitivity. Now this is very important for the microbiology lab to not put out 150 antibiotic table which says that it is sensitive, resistant, sensitive. Instead of that, you just give the first line drugs to which it is sensitive. So the temptation for a junior resident or for a junior doctor to start on a big gun is not there. Rapid viral testing methodologies for respiratory pathogens, which is an incoming thing and therefore can help to reduce empiric antibiotic therapies. Similarly, there are rapid testing methods which are now in the pipeline for blood specimen as well, and see if there is a role for biomarker guided antibiotic therapy such as procalcitonin, especially in culture negative cases. And patients with hematological malignancies, try to incorporate non-culture based diagnostic methods, monitor daily days of therapy and define daily dose for monitoring. Now this is important. Does it cost a lot of money? No, it doesn't. All you have to see is actually look at how much of antibiotics are used for a given patient and then look at the average of that and see how best you can use methodologies to reduce it. Assess your antibiotic costs not based on what the hospital purchases but based on what the patient spends. So that will give you a good idea of what is the antibiotic costs which are being employed on the patients. Measure of syndrome specific interventions that optimize antibiotic use and also have special guidelines for special subset of population of patients. So all these are guidelines from the IDCA. Now, did you spend a lot of money other than probably talking about some rapid diagnostic tests? I don't think we did a lot, isn't it? I just need 1 or 2 additional persons or already just re-employ or redeploy persons who are actually already in the hospital to help you actually target your antibiotic therapy, modify your antibiotic therapy, scrutinize your antibiotic therapy and guide people to stop it at an appropriate time. So with the guidelines that I spoke about, I think there are lots of possibilities, and should I ignore these guidelines? I think probably not. Now we look at the clinical and economic impact of these antibiotics. We were told in the last talk there's a lot of impact on money, lots of things that I need to spend, hospital management will not pay me this money, etc., etc. Now this is an interesting study. I just took up one recent one last year published by Karenin et al. A meta-analysis of about 25 studies when they screened more than about 250 odd studies in antibiotic stewardship program, and they found that in the 2025 studies which were reasonably homogeneous, they did notice that there was a trend towards restricted antibiotic consumption, there was a trend towards a change in the total antibiotic consumption, and also there seems to be, and there also seem to be a trend towards cost saving and shorter length of stay over a given period of time. So I think the myth about increased cost because of having antibiotic stewardship program doesn't exist. It's probably beneficial for you in terms of your quality control activity. And it seems to be successful in various settings. Now let us just go back to the different categories of hospital or community health services or even healthcare delivery systems that we have. We know that we have rural healthcare delivery, we have primary healthcare, community healthcare, tertiary healthcare. So and also long-term acute healthcare. There's an interesting study by Mushtaq et al. Published very recently which actually showed that employment of antibiotic stewardship program in a long-term healthcare facility seemed to make a huge difference in cost, reducing antibiotic requirement. Very sorry to disappoint my good friend Dr. Rajesh, though it was his birthday today, and I would also take this opportunity to wish him a very happy birthday. Thank you.